record. So this is our exam 1 review for next week. If everybody, well, if you would like to come on camera, because this is pretty interactive, so I'd like to see faces, if you don't mind. And the one thing I want you to pull up is your exam 1 study guide. I want you to pull that up because that's what we're going to be going through. Yep, that's it. I'm going to share my screen so I can pull that up. This one. Mine looks blank. Hopefully yours isn't blank, but if it is, we're going to get it filled out. Okay? So your study guide has outlined the different weeks, the 3 different weeks, and all the concepts. So we're going to go through and fill out these boxes on what we need. Now, I have a bunch of notes in front of me that I want to go through. So if I'm looking down and in the camera, I'm going through all my notes. Okay? So let's get started. So think about the exam in clinical terms. Okay, so you've learned the knowledge, you've learned the information. Now we're going to apply it into the clinical setting. That's how I want you to think about the exam. So it's the next gen format, right? Taking your clinical knowledge and applying it to clinical practice. Okay, so this is interactive, so I'm going to be asking you questions as well as giving information as well. Okay, so let's start out with introduction to community nursing. What do we want to know? We want to know the difference between community-oriented nursing and community-based nursing. So can somebody go through with me the difference between community-oriented nursing and community-based nursing? Remember, community-oriented, I think of the big picture. Okay, big picture.
Community. Oh, I'm sorry.
No, go ahead. Go.
Community oriented nursing is oriented around the community.
Mm-hmm.
That's what I have. And community based nursing is directed towards a specific group of people.
Right, right. So community-oriented nursing is focused on the population. Right? So let's think of a couple of examples of that. Let's say no, let me step back. Okay, you're focused on the population with community-oriented. Community-based, think of it as you're based in the community. You may be a school nurse working with kids, maybe an occupational nurse working in a workplace, maybe a hospice nurse working with hospice clients, a home health nurse doing home visits, right? A spiritual nurse or a faith community nurse providing care in the congregation. You're based in the community. All right. Another way to look at this is think of all the places in the community you could be providing care to be community based, right? Long-term care facilities, rehabilitation facilities, hospice care facilities, schools, workplaces. Just think about your community. Where does healthcare get provided? Medical office buildings, urgent cares, anything that's not the hospital setting. Right? So let's take, for example, you're a home health nurse in your community-based nursing. You're working with a family that has a newly diagnosed diabetic. Right? What kinds of things are you going to be working on them with? Let's say you're working in the schools and the nurse is working with an immunocompromised kid. What are you going to teach the parents? You think of the immunocompromised kid, you want to try and talk about, and those are the clinical settings. You're working with a new diabetic, you're working with an immunocompromised kid. What are you going to teach? What are you going to teach the the teachers, the aides, the instructors in the classroom about an immunocompromised kid. You're working with a new diabetic. What are you going to teach the teachers and the kids? So that's community-based, right? You're based, you're taking care of an illness in the community. Okay? When we think of community-oriented nursing, think of the risk factors when you're looking at the population as a whole. As a community, what kinds of risk factors might be there? Maybe there's a community that has a high poverty rate. Maybe there's a community that has risk factors. Maybe it's a elderly community, right? We know, and we've been talking about this for 3 weeks, that risk factors increase the likelihood of disease, right? Right. So if you're thinking community, big picture community, if you live in a community that has lots of risk factors, you're more likely going to find a higher risk of disease. Right. Let's say you're working with a family, you're doing home health visits, and they live, let's say the whole community is an older community with older homes. And you're teaching families about exposures to lead. Right? What are you going to teach them? What does lead exposure look like? So those are examples of community-oriented, community-based. Okay? Does that make sense? What else do we want to know? Is there anything else we want to know within this concept? It's really important to be able to distinguish between looking at assessing a population versus assessing an individual. Remember, in the community, inside the community where you're working, our client can be an individual, it can be a family, right? It can be a subset of the population, say the kids, the elderly, or it could be looking at population as a whole, which is the community-oriented nursing. Go, Brandy. Jump
Sorry,
in.
that's exactly what I was gonna ask you to kind of like touch on, was the community oriented and how it focuses on like the group within the community. You know what I'm saying? The population within the community, like the elderly,
Mhm.
the children. So you hit it as soon as I was about to.
Great, great, good. What other questions do you have about the differences, community-based, community-oriented? Okay, let's jump to levels of prevention. What do we want to know here? Well, let's review primary, secondary, and tertiary. Primary is prevention, trying to prevent something before it happens. Secondary S is screening. We're trying to screen for risk. I also like to look at secondary as early identification, early intervention. That's where I did all my teaching in the schools, especially with the middle and high school kids. Early screening. Who's at risk for obesity? Who's at risk for unintended pregnancies? Who's at risk for substance abuse? Who's at risk for mental illness? You've got to be able to screen to identify risk, right? Screening, blood pressure screenings, blood glucose screenings, health fairs, screening, identify risk, right? Because what we want to do is try and reverse that risk or minimize that risk so it doesn't turn into a tertiary issue, right? Tertiary, you have to have something. Okay, manage treatment of disease, management of disease. Okay. So let's think of, so let's say you're educating a family on seatbelt safety. Is that primary, secondary, tertiary?
Primary.
Primary. Let's say you are working with a group of high school kids and they're all getting their licenses. and you start to work, you talk about seatbelt safety. Primary, secondary, tertiary. Primary,
Primary.
right? They're working towards getting their licenses, so we're trying to teach them or trying to give them some education that will hopefully prevent injury in the event that they're in an accident with seatbelt safety. I'm just throwing out some examples.
So if they had their license and you were teaching seatbelt safety, that would be secondary or not.
No, that would still be primary. They have
That
their
would still be
license,
primary.
which is fine, but you're
Trying to
educating
make
them on safety issues with driving, such as seatbelt safety. Let's say you're working with a patient in the hospital that's had a stroke, and you're trying to organize sending them home with physical therapy, occupational therapy. What's that? Primary, secondary, tertiary.
Tertiary.
Right. They've had the stroke. Now you're trying to help them manage that by whatever they need. One of the things that Healthy People 2030 talks about that we didn't mention in class is safe education and safety. And in particular, let's take a home health nurse who's going into the home and doing an assessment. One of the very first things, and this is one of the Healthy People 2030 objectives, one of the very first things that they would assess for would be firearm safety. This is part of their national objective of family safety. Okay. So let's assume you go into the home and one of your first questions is, are there any firearms in the house? Okay, and there's a question about this on the exam. That's why I'm going over it. Okay, firearm safety. So if you go into the house, you want to know, do we have any firearms? If the answer is no, okay. If the answer is yes, what are the important things to know? Or what's the most important thing to know? Yes, they have a firearm, but okay. So what do we want to look at? What do we want to find out?
Where is it?
how did how
Where
is it being stored? Yeah.
exactly? Show me where this firearm is stored, right? Because you want to make sure it's stored safely. I mean, think about it. You're a home health nurse out in the community by yourself in people's homes. There's lots of risks attached to that. So one of the first things we want to know is firearms. Do you have any firearms? And we want to know where they stored. Show me where they're stored. We want to assure that they are safely stored in the proper way. That comes right from Healthy People 2030. Okay. We talked about this is still in Healthy People. We talked about risk. What increases risk? Your age, right? Your comorbidities, sometimes your race, your ethnicity. What else potentially increases risk?
Education level.
Education level, access to health care. There's lots of things that may increase your risk. And who's the most vulnerable population?
Well, today I learned the veterans.
No, let me rephrase that. What
Okay.
age group, age-wise, who is the most vulnerable?
Those children?
Kids. We talked about that in length in class. And remember, in your Healthy People 2030, remember they talked about the social determinants of health. There's 5 of them, right? What's a social determinant of health? Things that impact risk, right? Do you remember what the 5 were?
Economy,
Financial,
Education.
Hang on, I need to go back to 1 second. I want to give you those 5. I didn't outline them in the 1 second. They were in our week 2. Hang tight. Ooh. Social determinant, no, that's week 1. 1 second. Okay. Social determinants of health are on page 2 of your week 1 notes. Economic stability, education access and quality, healthcare access and quality, neighborhoods, and social and community. So all these things, whether they're, however they're playing into the function, you know, the family, the individual, the family, right? Here's some examples. Do people have safe housing? Do they have transportation? Do they live in safe neighborhoods? These are all social determinants of health. These play a part in how things are. Is there racism, discrimination, and violence in your community? Education, job opportunities, and income. These are all this is in your notes in week 1. Do they have polluted air, polluted water in their communities? That makes a difference. And language and literacy skills. That plays a huge part. What if you have a population that doesn't speak English? How do you get to that population? How do you educate them? How do you communicate with them? Okay, so these are all part of the Healthy People 2030 objectives. Okay, and let's remind ourselves, healthy people. It's increasing the health of everybody, right? Or increasing the best health outcomes for everybody. It's a national campaign. Okay. What else do we want to add in there? Anything else? I think that's good. Introduction to vulnerability. What do we want to know? What are some causes of vulnerability? Or what are some categories of vulnerability? Who's vulnerable? Who do we list out? Who do we identify as being vulnerable populations?
Children.
Children,
Elderly.
elderly, veterans,
Yeah.
right? Pregnant teens, people with substance abuse issues, people with mental health issues. We know our migrants are vulnerable, right? People with chronic complex illnesses, they're vulnerable. We also know that one of the primary causes of vulnerability is poverty. We've talked about that in class. What are other things that make people vulnerable? Lack of access to health care, lack of access to quality education, lack of access to quality nutritional foods, disabilities. I mean, education plays a role, learning disabilities play a role. You know, whether you're single living alone versus living with a family with support. All those play into vulnerability. And we talked about some interventions. How do we work with vulnerable populations? We talk about establishing a trusting relationship, using therapeutic communication, not being judgmental, listening to their story, letting them speak. Another thing we talked about with introduction to vulnerability, we talked about this in week 2. It comes from week 1. Information is resiliency. Remember the conversation about resiliency? That's one of our jobs as a community nurse, is to try and increase the resilience of people. Right? Remember, resiliency means, what is resiliency? You're going to try and overcome risk factors and situations and conditions that may increase your vulnerability. So one of the things we do is we help with resiliency, trying to help people or families or groups of the population become more resilient. Because the more resilient you can be, what? The better choices you're going to make. You're going to lower your risk of getting a condition, getting a disease, having an accident. So one of our goals is to increase resiliency. We know that vulnerable populations often have chronic diseases, right? So let's say we're working in a home with caregivers of the chronically ill client. What do we want to make sure they have? Are they as at risk of developing issues, being the caregiver? Of course they are. So what do we want to make sure with the caregivers? What do we want to discuss with them or assess with them?
We want to make sure that they're not having caregiver burnout.
Exactly. Well, think about primary, secondary, tertiary with the caregivers. They're important. They're as important, almost as an important part of the equation as the actual client, right? So a primary, what would we do for a primary? We would try and teach them or educate them on maybe the signs and symptoms of burnout, right? Of trying to help them understand the stressors that go along with caregiving, right? Preventative, trying to prevent any issues. And in secondary, we screen. How do we screen? Maybe we ask, how are you doing? What resources do you need? Can you plan some time away and others take over? Right? And then tertiary. Let's say they do have burnout, or there have been reports of maybe neglect. We already have an issue. So now we have to try and help them.
Wait a minute.
Try and help them manage whatever stressors they're experiencing so that they can continue to provide effective care. Right? So we have to think about the caregivers. Okay. Any questions about, think about direct care with clients, direct care with caregivers as we're moving into this exam. It's very clinically focused. It's about taking care of clients with the knowledge that you have. Okay, what's the school nurse do? What kind of roles does a school nurse have?
She may help like a student with their medication.
Maybe teach about side effects for medication, or maybe teach a kid with asthma how to use his inhaler. Maybe teach a kid that's newly diagnosed with diabetes how to check their own blood sugar. A lot of education, right? Maybe preventative education. You know, I know with the preschoolers, I could start one day in the preschool talking about good hand washing. And I could finish up at the end of the day being in a high school talking about prevention of substance abuse. A lot of education. Making sure the kids are healthy during the school day. One of the things that we don't do in school, we don't diagnose system resources, some stuff. All right, let me see if I can close some stuff. Wanted to, okay, let me back in here. Hang tight. Now, why can't I make you guys bigger? Okay, hang on. Oh, because I'm screen sharing. Stop sharing. Okay, I think we'll just, I don't know how to pull that back up again. Okay, that's okay. All right, so school nurse, right? One of the things we do not do is diagnose and treat. Okay, we may be educators, we may be direct caregivers, but if we have issues going on in the schools, we're going to contact the parents, right? We're not going to say, I think your kid has conjunctivitis. We're going to say, well, you know, his eye's itching, it's burning, and it has some drainage. You know, we think that you need to get seen. All right, but we have to be careful as nurses, okay, about presenting the situation to the parents and letting the parents decide what to do. You can encourage them to do things, right? Here's how your student is presenting. Does that make sense? What other roles? School nurse plays a role in the special education students, right? With services the students may need during the school day: physical therapy, occupational therapy, speech therapy. We also act as consultants. We communicate with physicians about school issues, right? And we're teachers. We work with the teachers, the administration, the students to teach about conditions and treatments, and who's got an EpiPen, who has an inhaler, right? And let's say you have a scenario of a student that's coming into the clinic multiple times a day, multiple times a week at the same time. And it's been going on for a month, and you say, you know, I know you don't have a stomach ache. What else is going on? It's okay for the school nurse to move that forward. That's that risk. That's that secondary risk. The student has been coming in, right? We know there's something's going on besides a stomach ache. It's been a month, right? You've already called the parents. Does Susie have a stomach ache at home? No, 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 no. Well, she comes into the clinic every day after fourth period. What can the school nurse do? Or what should they do? once you've identified a student who's potentially at risk, why is she coming in at the same day, same time, every day? What else happens in schools that we need to be aware of, that we need to inquire about?
Bullying.
Bullying.
I know exactly. Exactly. What were you doing before? What's going on? You come here at the same time. What's going on in the class prior? What's going on in the class ahead? Right? You need to be able to, school nurse, sort that out. Maybe you talk to the teachers. Is there anything going on in your class? Or the teacher ahead. Is there anything going on in your class? Is there any bullying going on? Is there any abuse going on? Right? So as a school nurse, we have to be able to take that next step and clinically look at a student who comes into the clinic and be able to ascertain, is it really a stomach ache or a headache? Because that's what they all come in for. Or is there really something else going on? Okay. Let's see. Growth and development. What do we want to know about growth and development? Let's say we're teaching, what we want to know in growth and development really is, let's say since we do a lot of teaching, right? What are the appropriate, how do you teach a 4-year-old versus how do you teach a 14-year-old? Right? What's their attention span? What are they able to comprehend? Right? Let's say you have a new diabetic student and let's say they're a middle schooler or even late elementary school, and they want to start learning how to test their own blood sugar during their own injections. Is that age appropriate? Sure. Why not? Right? The goal of diabetes is independence. The goal of diabetes teaching is teaching towards independence, right? Let's say we're we're working with a family for risks of obesity, right? When we do our teaching with obesity teaching with these families, or with the kids, what are they able to comprehend? How do you teach a elementary schooler prevention or education on the future risks of obesity versus teaching a high schooler? Right? And since community nursing involves a lot of teaching, we have to be able to make sure we are aware of what kids can comprehend. Can a preschooler sit there for an hour and listen to the risks of obesity? Probably not. Does that make sense? So we have to think about our teaching strategies, which is why it's important to know about growth and development, what they're able to comprehend. Okay. What else do we want to know about growth and development? Let's jump into common childhood ailments. There's a lot of questions on the exam about common childhood ailments. So we need to review that. Okay. One of the common childhood ailments that we didn't review in class, I want to bring up that you're going to see on the exam is cystic fibrosis. Okay. It wasn't listed in our common childhood ailments, but we need to be aware of it. What is cystic fibrosis? Have you learned about this in peds yet? Okay, cystic fibrosis. Is it inherited or not inherited? It's inherited. Okay. What is it? Cystic fibrosis is pulmonary, right? It's thick mucus. Thick mucus that can't be excreted, so it causes blockages. So how would we care for cystic fibrosis? Let's say you had a kid with cystic fibrosis that presented to your urgent care?
We would try to thin out the mucus.
What might they present with? Coughing, trying to expel mucus. They can't. So what's going to happen? Maybe increased respirations. What are they going to present with? Maybe high heart rate, increased respirations.
Difficult to breathe.
Pardon me?
Difficulty to breathe.
Yeah, difficulty breathing. Yep. So I want you to be aware of that. Okay. Let's jump into asthma. Let's say we're caring for a kid with asthma. What might we see? What might they present with if they're having a asthma exacerbation or asthma attack? What are we going to see?
Short of breath is wheezing.
Short of breath?
Retractions, intercostal retractions.
Yep. Color?
The nose is fluttering.
Flared. What else? What else? Are we gonna see?
Wheezing.
Hmm?
Wheezing.
Mhm,
The posture to breathe.
mhm. And how are we going to care for them?
Remain calm. Give it oxygenation. Give it the bronchodilator.
Think
With the
about
spacer if
kids
it's
in school.
child.
Think about kids in school. Do you have an inhaler?
They might have if they know are asthmatic, but if they
Right.
don't have,
Let's say they do have an inhaler. We're going to be encouraging them to use their inhaler, watching them use their inhaler, see if we get some relief, right? Watch them before they go back to class. What if they don't have an inhaler?
and remain calm and help them to breathe slow and
Mhm.
encourage them to again
Exactly.
get their normal heart rate breathing.
Right. These questions on the exam about these common childhood ailments are clinical questions. The kid presents with scabies, the kid presents with asthma, right? So read back through your notes on common childhood ailments. What might be some of the causes of asthma?
Allergies
Allergies?
and season,
Mm-hmm.
sports,
Exactly. Sports is a big one.
um,
Exercise-induced asthma is a big one,
some
right?
other
about-
triggers like a pollen,
Yeah. Environmental issues,
yes,
dust,
smog.
pollen. Yep. Sometimes allergies are triggered, asthma can be allergies triggered by foods. Asthma and
Yes.
allergies a lot of times go hand in hand, right? One of the things we need to be able to figure out with these kids with asthma is what triggers it for them. Is it a food? Is it a pollen? Is it exercise? Right? So that we can help work with them and come up with the best treatment plan. Another risk factor for asthma is being around secondhand smoke. Right? A lot of kids live in households that are smoking households. So if we're working with the families, what do we want to teach the parents? Obviously, we're trying to work towards a smoke-free home. What do we want to teach them? What do we want to educate them on?
To no smoke nearby to the kids or quick smoke.
Well, yeah, we want them to quit. That's the ultimate goal. Maybe provide them resources with
Yes.
quitting programs, right? Maybe encourage them to smoke outside for now.
Yes.
I mean, not the best case scenario, but it's better than smoking inside, right?
Right.
What about the parent says, oh, I cut down, I only smoke 2 packs a day instead of 3 packs a day. Well, that's really not going to help. What about the parents that want to use e-cigarettes or vaping? Is that going to help?
No.
No, no, no. All right, so we have to think about smoking as a trigger for asthma. Okay, let's talk about eczema. What's eczema?
Allergy
causes
to
it?
the, were they sweating so much?
Well, yep.
When
That's
this,
what,
it's like
that's why we
some
talk about,
condition allergy, like they sweating so much and triggering their skin with
Mhm.
rashes, skin rash.
Yeah.
Um,
We
other,
work with a lot in the high school settings with sports and the sweating, causing different kinds of rashes and eczema. Yep. What else? What else triggers eczema? We know that eczema is
It-
common with asthma and allergies, right?
like kind of clothes, the clothes they use,
Mm-hmm.
the
Any kinds
showers,
of new detergents or
Detergent,
shampoo. What?
lotion, detergents.
at detergents at the same time you said detergent.
Exactly. Exactly. How do we treat eczema? Let's say a parent that goes into the pediatrician is talking about, eczema, all they do is itch and itch and itch. What are some of the treatments? What's a primary treatment?
Oatmeal bath, maybe.
Okay. Yep.
But with no lotions or shampoos with lotions,
Yep.
creams,
Yep.
Cutting the nails,
lotions,
making the nails short.
Yep.
and nails.
Yep. What about if you had to give the kid medication? What kinds of medications would help with the itching?
Antihistamines.
Antihistamines.
Yeah, I forgot the name.
Yeah, antihistamines. There's a good treatment for eczema as well if it can't be controlled by all the other things you guys just said. Right? Let's talk about type 1 diabetes. Okay? And let's talk about education. Let's say you're working with a kid, education. Let's say it's a new kid, and they are expressing interest in giving injections, and you feel like age appropriate, it is good. What's the best way to teach them? How do they?
With some toy,
Mm.
using toys,
Yeah, if they're
something to
going to practice,
demonstrate him.
yeah, they're going to practice giving injections. We want we want them to demonstrate back to us. Right? We don't want to have them watch a video or, go to a class that may be helpful. But if we're teaching them one-on-one, we want them to practice injections. We want them to hold a needle. We want them to practice giving it into a stuffed animal or a doll or a pillow or something. We want to give them that experience, right? So they know what it feels like. What else do we want to do with teaching diabetics how to take care of themselves? New diabetics.
To they demonstrate what they learn, like teach back, show
Teach
how
back.
they.
Teach back method. Very important. Teach back method for checking your blood sugar. We want giving injections, setting dials on your pump. We want them to demonstrate back to us. That's the way the teach back is. We teach them, they teach, and then we observe how they're doing it. Right?
And also we can teach them like how to prevent infections, like skin wounds, and how to, like wear socks and stuff like that. Just
Good hand washing. Absolutely.
yeah.
Right. So think when we're thinking about diabetes, I want you to think about you're working with kids or adults or elderly that are newly diagnosed. What do we do? What's the best way to teach them how to care for themselves? Right? Because ultimately we want them to be independent. Right? Nurses spend a lot of time in the schools. I spent a ton of time in the schools. We had, I think, 600 plus diabetic students in our district. We were always working with diabetic kids, right? And it's always a goal towards independence, right? Okay, conjunctivitis. What's conjunctivitis? What are you going to see? What are you going to see in a kid that comes in to your clinic or the school clinic or The neighborhood clinic, what are you going to see with a kid with conjunctivitis? What are they going to
Pink eye.
Pink
present with?
eye,
redness,
redness,
redness on the eye.
Redness in the eye, itching, maybe
swelling.
some swelling, maybe some drainage, right? What is it caused by? Conjunctivitis.
Bacterial,
Bacterial, right? Maybe allergens, right? Allergies can cause conjunctivitis, right? What are we going to teach? What are we going to, if we're working with a kid with conjunctivitis, what do we want the kids to know? What do we want the parents to know?
They need to
What?
like wash their hands. good
Hand
hand
washing.
avoid touching your healthy eye.
Exactly. And these kids will need to be treated, right? That was one of our quiz questions. They need some bacterial eye drops, right? They can come back to school once they've started the treatment, but they need some kind of treatment.
the warm cloth in the eyes,
Mhm. Well, that was my next question. Do we do warm cloths or cold cloths?
warm.
Warm.
Warm cloths to the affected eye. Okay. Scabies. What is a kid going to present with wherever? School clinic, neighborhood clinic, what are they going to present with? What are they going to have?
A lot of itching,
What's scabies caused by? Do you guys remember?
parasites.
Parasites. Right. And what happens? Yeah, they're going to present with itching, but what is it going to look like? What is the actual scabie going to look like?
a rash with like vascular,
Like a bumping.
vascular, like marks underneath the skin.
Underneath the
Yeah.
skin, burrows underneath the skin. That's what these parasites do, right? They burrow underneath the skin. How is it spread?
Direct contact.
Direct contact. So when you're the school nurse and you're teaching and you have to call a parent, we had actually a checklist we would send home, but you're calling a parent to say, hey, it looks like your kid has a rash. I'm not sure what it is because obviously you can't diagnose them with scabies, right? But it looks like they have a rash underneath their skin, right? What do we have to tell the parents they have to do with scabies? Well, we know that the child's going to need to be treated, right? But who else is?
With
Everybody.
ivermectin.
What?
I'm sorry.
No, go ahead.
Ivermectin.
What, Celine?
Ivermectin.
I'm not
That kind
understanding.
of lotion. I don't know.
There's a
Maybe I
special
confuse it with
special
other.
treatment.
Like wash, we're gonna wash like all their clothing, their teddy
Exactly.
bears, stuff like that. Don't we put them in a bag for 3
You-
days?
Clothing, ready? Clothing, bedding, stuffed animals should be washed and dried on high heat,
Mhm.
right? Here's your answer, Brandy. Non-washable items can be bagged up for at least a week since these parasites will die within usually 3 to 4 days. Does that answer your question? Who has to be treated?
All the
Everyone.
family.
Everyone, right? Any family members, close relatives, babysitters, anybody that's in close contact with the person who has this breakout. And you guys remember that from your notes, right? Okay, lice. Oh, let me go back to scabies. I have a question. Who can get scabies?
Any animal.
Everybody.
Anyone. Sometimes there's this misconception that or a stigma that it's with people who don't have good personal hygiene. That's not the case, right?
Mhm.
Okay, let's talk about lice. What does lice look like? Does anybody ever? I've had to do it a gazillion times. Anybody ever have to check people with lice? I
Mhm.
know. Lexi's itching. I used to come home many days from my school nursing job itching when I had to check classrooms of kids full of lice. What do we want to know about lice? It's at the base. It's at the base of your hair follicles, right? It can be live or it can be nits, right? How is it transmitted? Hats, combs, brushes, school. The teachers used to think that they couldn't put all the backpacks where they normally are because they thought that lice jump from one backpack to the other.
Mhm.
So we had to do that education. Okay, that's not the way. Lice is direct contact. So we used to have, kids having sleepovers, a group of second grade girls having a sleepover and everybody ended up with lice. Right? It's direct contact. It is not just like scabies. It is not, lice is not related to uncleanliness. We know that, right? But that's a misconception, right? The other misconception is that it happens, oh, you only get lice if you have dirty hair, or you don't wash your hair. That's not the case either, right? Lots of lice is a hot topic, but it happens. And it doesn't just happen in the schools. It can happen to anybody.
Mhm.
Okay. We know treatment. They have to get treated, right? With whatever product you're going to use. Retreatment in 7 to 10 days, right? What else? I think that's all we want to know about lice. So, what would they present with? Let's say a kid came to the clinic in school. They're itching. Sometimes, if their head is full of live lice, you can observe that close up, right?
Mhm.
But many times you can't observe it close up. You've got to bring them or bring the person. You need a special, sometimes, a lot of times you can see it with the naked eye, but we used to have our little microscope things in the clinics to be able to look at those hair shafts at the bottom and see what was going on. Okay. ADHD. Okay. We talked a lot about ADHD during our 3 weeks of or during our common childhood ailments. There's lots of misconceptions too. Okay. Think about a child presenting, let's say you're a para in the classroom. Okay. What are they going to present with? Maybe unfocused, right? They're distracted easily. They're impulsive. But a couple of misconceptions about kids with ADHD. They don't automatically need a one-on-one para, do they? Some may, but overall, you can't make the assumption that all of them need a one-to-one para. The other thing, too, is we can't make the assumption that they all need behavioral plans. Some may, right? If it's not under control. Some may not. We don't want to isolate them, right? We maybe want to put them up in the front of the classroom for purposes of having a better chance of paying attention and being less distracted in the back of the class. It's not punitive, right? But think about it. They may need reminders to take their medication. Let's say they're on ADHD med. They may need reminders to go to the clinic, right? That's all part of what ADHD is: forgetfulness, distractibility. So it's okay if they need a reminder to go take their medication, right? We don't want to punish them by taking away activities such as recess, right? That only hurts them. They need that outlet of exercise. There's a lot of confusion about how we work with these kids with ADHD. Some may be on medication, some may not. Placing the child in the front of the classroom could be helpful. It's not meant to be punitive. like single them out because they're in trouble and put them in the front. No, we want to put them up there so they give them the best chance at learning, right? They need short, clear directions. They need breaks in between their activities, right? What else? What else about ADHD we want to know? We're obviously striving for the best outcome, but we have to recognize what the basic issues are with these kids. Lack of focus, distractibility, forgetfulness, impulsiveness. But we can't treat that as punitive. Okay? Iron deficiency anemia can be serious. Iron deficiency anemia can be really serious if it's not treated. Right? What kinds of foods would you suggest to parents who say you're working with parents and teaching them about iron deficiency anemia? What kinds of foods do you suggest would be best?
Green leafy foods.
Okay. What else?
Eggs,
Eggs. Why eggs?
why eggs, milk.
Go back to eggs.
Meats,
Why
meats.
eggs?
It's a good nutritional source for iron.
Exactly. Exactly. Right? Whatever nutritional sources are good for iron, that's what we want to be working with these parents about. Okay? Eggs, liver, green leafy vegetables, cream of wheat, beans, nuts. Okay? Untreated iron deficiency anemia. Which is serious. What would a kid present with? It was in your notes. So go back and read through that. What they present with is difficulty breathing, dyspnea, right? Edema, extremity edema. Okay.
Heart
What are those signs of?
and heart failure.
Heart failure. We have to be mindful of that. Well, Ania, great. So what I want you to do is if you want to finish up, we started an hour ago. So anything after an hour, watch.
Okay. Thank you.
Watch the end of it. We're almost done. Okay. Scoliosis. Hang on. What you need to understand is the difference between scoliosis and functional scoliosis. What's functional scoliosis? We didn't go through this in class. What's functional scoliosis? There's a difference. Functional scoliosis has to do with posture. Okay. Regular scoliosis is that curvature, right? And so let's say we were doing a screening for kids with scoliosis in the school. How do we screen? What do we do?
Have them lean forward.
Lean forward.
And
At the
check the
weight.
shoulders and
Hang on,
the
Brand.
and
Hang on,
use
the back, the
Celine, hang
curvature.
on. Celine, hang on. Brandy, go. What do you do?
That's as far as I know.
Bend forward at the waist. And
And
what do
check
you
their
look?
back.
And what are you looking at? You're looking at for symmetry,
Symmetry, yeah.
right?
Mhm.
That's scoliosis. Functional scoliosis. Let's say a kid presents with functional scoliosis. That's the posture scoliosis.
So they could be leaning to the side if they have functional scoliosis, maybe leaning.
Well, the difference is one is related to posture. So we're going to be working with them on better posture for functional scoliosis.
Oh.
Celine, what did you want to add?
No, it's the same. The
No, they're not
posture.
the same.
Well, the functional and the
Right.
the
Just
regular.
remembering that functional scoliosis has to do with posture.
Okay.
It's a posture issue. It's not a symmetrical issue from the actual scoliosis disease. Okay.
Okay.
Here's some of the things you might observe. One as you're bending over and looking at the symmetry of the back. One shoulder might be higher than the other. One scapula might be more prominent. The arm to body spaces may be unequal. This is all in your notes. I'm reading this from your notes. One arm may appear longer than the other when bending forward. Okay, that's right from your notes. So functional scoliosis is usually caused by poor posture and is not a spinal disease. Okay. Lead exposure. What's the primary thing we need to know about lead exposure? Where does the exposure increase? What setting might your lead exposure increase?
In old buildings.
Old buildings, old schools, old daycare centers, old homes, old workplaces prior to 1978. Okay. And kids exposed to lead may present with cognitive issues, right? Developmental issues. Lead exposure, let's say kid might present with some other symptoms, headaches, abdominal pain, constipation, clumsiness, agitation, reading right from your notes, maybe even convulsions. So as part of your assessment, as always, right, where do they live? If they're older, where do they work? What kind of work do they do? Right? Where they live, where they work. You got to do that's part of your assessment. Okay, that's week 2. Let's jump to week 3. We talked about knowing the differences between acute and chronic pesticide exposure. Go back to your week 3 notes and read that highlighted section. You have to be able to identify what presents with chronic and what presents with acute. And think of chronic, if they've been working on the farms for years, they've been chronically exposed. And that brings up different issues than acute exposure. What's one of the other big risks, huge risks, biggest risk for migrants? Pesticide exposures. We just kind of talked about that, but that is their biggest risk. Let's think about all the challenges that migrant farm workers have. Maybe education or language literacy. They don't speak English. Transportation issues. What am I trying to say? Understanding health directives, healthcare. If they can't speak or understand the language, how in the heck are they going to seek out healthcare? How are they going to be able to describe what's going on? Right? Or understand what the discharge instructions might be. What resources are available to them? They usually lack that information. They typically don't have health insurance. Or if they do, it's very underinsured. They're not eligible. They're not eligible. Migrant workers, I don't know if you know this, are not eligible. They're eligible for a lot of resources, but one resource in particular they're not eligible for is the SNAP, the supplemental nutrition. They're not eligible for that. It's not automatic. Okay. We talked about housing. A lot of times these migrants are set up in very overcrowded, unsanitary housing. It's in your notes. A couple of risks that are mentioned in your notes. Risk for TB, risk for GI disorder, risk for some infectious diseases like hepatitis. Very common. Okay. It's about the lack of English, the lack of employer health benefits, not available for supplemental nutrition. This is all from your notes. Okay, so if we're taking care we're moving into rural now. If we're taking care of the rural population, what are we likely to observe? Chronic diseases, increase in chronic diseases, right? Increase in substance abuse, increase in mental illness, high risk occupations in the rural community. How do they all come together? What do they, a lot of times they use their churches. That's their social gathering place. That's their social support. They don't have a lot of resources in the rural communities. Right? So they come together in smaller ways, churches, schools, Bible study, those kinds of things. They don't have the great big resources that the big populated areas have. They're very close in a community. They don't welcome outsiders, right? Everybody likes to be in their little group, right? Everybody wants to know everybody and know everybody's business. We talked about this earlier, right? Very tight-knit community. Any kind of outsiders are a threat. Okay. High risk occupations we talked about. And the other thing we talked about is they perceive their health as not a priority, right? They're not seeking out preventative care. They're really not seeking out secondary care for the screenings. So by the time we see our rural populations, they're usually in a crisis state or their condition or disease is pretty advanced, right? What else do we want to know about our rural population? High levels of depression, high levels of poverty, insufficient number of health professionals, mental health professionals, delays in seeking treatment. They don't have jobs that have vacation days. They don't have jobs that they have typically hourly working, daily paying jobs. So it's one of the reasons they don't prioritize their health. They got to take the whole day off and not get paid. Right? Let's see. Disasters in communities. Let's say there's a local disaster in a community. A hurricane came through, or a flood from a river, or a lake, right? Rural communities want to try and handle things on their own, right? They're very group oriented, right? So if there's a disaster in the community, they want to try and resolve it with their own community resources before they reach out to state, federal, local officials. They want to try and resolve things. Rural community, the other place I lived during the year is up in Wisconsin, way up in Northwest Wisconsin. Tom and I have a place up there, and it's about as rural as it gets. Very tight-knit community. Everybody supports each other in their own ways, right? Very tight-knit. Everybody knows everything about everybody. Everybody knows when the next bingo game is and where it is, and everybody knows everything. But they know everything about each other, but they want to keep it that way. Tight-knit group. Okay. Homelessness. We talked about trust, therapeutic communication in your initial interactions with the homeless. Right? Homeless, they're not going to have insurance either. They're not going to go to primary care visits. Right? Where do homeless people seek out their care typically? Why is it so expensive for the homeless people, or the care we give to homeless people? Where do they seek out their care? Where do they go?
They used to go to the ER.
The ERs. That's where they seek out their care. They're not going to their primary care physician. They're not going to the local health clinic to get their screenings. Right? We typically see the homeless population in the ER, which is the most expensive expensive way to seek care. Right? And that's why getting in there and working with them, building trusting relationships, we can hopefully get them the resources within the community to get to a primary care visit, to get for a medication evaluation, to get for a screening. So it's not done in the ERs. So working with the homeless is so important to try and establish what's going on and what you can do to help. They don't prioritize their care either, just like the rural population. They're spending their time trying to survive, right? That's what they're doing. Okay, they're not worried. They're not worried about a yearly hypertension screening, right? They're worried about how they're going to survive, and if they have a family in tow with them, they're trying to figure out what resources these kids need and how to get those. Okay. Poverty, last area, poverty. Which population is impacted the greatest by poverty? We talked about this in class this morning.
Childs.
Kids. Okay, kids. The greatest, here's a statement. It's in week 3 of your notes and it's highlighted. The greatest impact on a child's overall health is the financial stability of the family. Think about it. If you live in poverty, everything is affected. Right? We talked about what age group is most at risk? Kids. It's not that the elderly isn't, but if you're asked who's most at risk, kids. Right? And we know that living in poverty, I want to speak about kids in particular in the school setting. They are academically impaired or potentially academically impaired, cognitive delays, developmental delays. So we have to pay attention to that. Okay, it really has to be assessed. I had a couple of schools in particular that almost 100% of the kids, the population were living in poverty. The amount of developmental academic issues was profound. Okay, so yes, poverty with kids affects academic, it affects nutrition, it affects health, it affects what else? Social integration. Okay, so really important for you to know the impacts of poverty on kids. We've talked about that a couple of times here and in class. So there covers your 3 weeks of concepts. A lot of what we just talked about came right from your notes. Some of what we talked about came from your readings. Okay, so I prepared this review based on what you've already had. Your lectures, your weekly notes, your weekly readings, and then what we went through today. So there's a few things today we covered that we didn't cover in class. So take that as that's information expected for you to know for the exam. Okay? Helpful. We spent 1 hour and 15 minutes. Is this helpful?
Yes.
You sure? Okay.
Yes, ma'am.
I'll do the recording. I'll get a recording in a little bit. And then I'll send that out this afternoon. And then everybody will have it. So if you want to review this, probably a good idea to review this in a couple of days, but everything's pretty fresh in your mind. I saw everybody taking notes, so that's good. Yeah, you guys will be fine. We've hammered this out the last 3 weeks, so you guys will be good. And if after reviewing the recording or coming to this and like I said in my class today, doing your due diligence of preparing for the exam, if anybody would like to get together before you take the exam any day next week, just shoot me an email and we can jump on Zoom and review anything that's still unclear to you. Okay? Okay, Brandy, I want you to stay on for a second. Everybody else, does anybody have any questions? I hope this has been helpful. You guys will be fine. All right, today's Friday, so have a good weekend.
You
Thank you
too.
so
All
much.
right,
you.
bye. Bye.
Bye.
Thank you. Bye bye.
All right, bye, guys.